Hello everybody. Today you will have a new adventure related to delivery room. We are so glad to announce our guest today, Dr. Sridhar, neonatal consultant. Thank you so much for having you today, Dr. Sridhar.
Thank you, Diane, for inviting me.
It's a pleasure is ours, of course. Firstly, I need to ask about your medical background, so please go ahead.
So I am a consultant neonatologist. I was trained in India and UK, and I was working as a consultant in UK and Scotland for nearly 7.5 years. And I moved to UAE in 2012. I've been the head of the department in many of the neonatal ICUs in both Dubai and Abu Dhabi region. And in the past 1.5 years or so, I am in Mediclinic, Al Johara Hospital in Al Ain. So my areas of interest is obviously newborn resuscitation, neonatal ventilation, and infant feeding.
Yes, exactly. Based on this wide background and experience, today we will invade all tips and the tricks beyond neonatal resuscitation. So, Dr. Sridhar, firstly, can you paint a picture of common delivery room scenarios that might necessitate resuscitation and factor influencing its success?
Yes, I mean, obviously the factor influencing success is the part I can deal with first, because team preparedness, training and preparedness of the team is going to be the key. And you need a good leadership who is aware of the situation you are in. You need to prepare in advance, because resuscitation is something which is emergent. You need to do it immediately to save lives or to optimize the outcome. So you cannot on the ground think that something else could be done better. So you have to prepare and keep things ready. And as a team, you need to train, and we will be discussing the neonatal resuscitation program, how the skill drill can be conducted in the unit, scenario, simulation-based training, and so on, to keep the team working together. So preparedness of the environment, equipment, and the team, these are crucial to improve the outcome. In terms of scenarios that involve resuscitation, obviously, labor and delivery is a natural process. But we have some situations where it doesn't all progress as you would want. For example, the mother may not progress, and she may need a cesarean section, which is emergency cesarean. There may be meconium staining like her. The baby may come premature, in which case their adaptation after birth is not adequate. So basically, in most of the cases of deliveries, we are attending the delivery to ensure that there is a smooth transition. So in some babies, we need a little support. But in 95% of the cases, we don't need any active intervention apart from the regular measures. So there are about 5% to 10% of the babies who will need support, and prematurity plays a big chunk of that. We do have babies with birth asphyxia, where you have fetal distress. Sometimes we have something called a sentinel event. You may have with a cord prolapse, you may have antepartum hemorrhage. And these are real emergencies, and fetal distress is where you have signs when the obstetrician monitors, there are signs that the baby isn't tolerating the labor process. This happens more in a baby who is growth restricted or who is small already, but it can happen in any delivery where the uterine contractions are very strong and there is not enough time for the blood flow to reach the baby. So where there is a stress to the fetus that the fetus isn't coping with, you are more likely to need. Where the baby is very small or immature, you are more likely to need. So I hope this answers your question on the scenarios where you need resuscitation.
Great. So Dr. Sridhar, can you walk us through the typical steps involved in neonatal resuscitation, emphasizing the importance of each intervention?
So basically we have the neonatal resuscitation program, which is well designed, and most of the countries follow the structure of the neonatal resuscitation program. So NRP is basically from the US, but we have similar entities in Europe. The international ILCOR, we call it, that is the body which formulates the guidelines for resuscitation, and the local bodies like the AAP, they modify it and form their own guidelines. For example, the American Academy takes over as the NRP, Neonatal Resuscitation Program, and in Europe, we have different levels of it. In UK, for example, we call it the Neonatal Life Support, or NLS. So the training is, the background is similar, the approach is similar, but slight differences. So according to which school of thought you're following or which certifying body you are using, there may be slight differences, but the approach to resuscitation is basically the algorithm. And these programs make sure that the algorithm is structured, it's easily followed, they apply it and get feedback from the community, and they modify it according to the new research that's coming out. So the algorithm is very well described. So it starts with how you assess the pregnancy, the risk factors before you attend the delivery. You look at the equipment check, you look at the actual condition of the baby when the baby is born, and then according to the situation of the baby, you progress along. We have many different tools available for assessing the baby. Now we have pulse oximetry, which is advised to be started early if the baby needs resuscitation. We have ECG leads that can be connected where the baby needs chest compression. We need resuscitation equipment, which basically is heating equipment. We have ability to provide a heat source, usually a radiant warmer. In very premature babies, we may need additional interventions like plastic bag and so on. We need oxygen and gas source, and you need material to give positive pressure. Usually it's either a TP's device, which is preferred these days, or the bag and mask ventilation, but with a manometer attached where you can give a positive pressure through that as well. So we have advanced things which we will discuss later, like interventions like umbilical venous catheter, boluses, and medications, and so on. So all this has to be packaged together in a sequence. So the main thing is look at the factors, assess the baby, and action at each step according to what you find. For example, if the baby is active and crying and is pink, you start skin to skin care with the mother. Just observe the baby. We don't even do suction or anything. The baby can be dried while on the mother. And remember, delayed cord clamping is advocated in all cases as well. If the baby is not breathing, then you assess the baby's heart rate. And if the heart rate is low, below 100, or if the baby is not breathing, you start positive pressure ventilation. And the most important step in the positive pressure ventilation is to make sure the chest is rising before you go on to any other steps. So because in neonatal resuscitation, the lung needs to get oxygen in, and the oxygen needs to go into the circulation. So unless the lung gets the oxygen, the further steps are not going to work. And that's why we focus on inflating the lung, and we have steps for making sure the inflation is working. When you keep the mask on the face, we have an acronym called Mr. SOPA or MR SOPA. So we can adjust the mask, reposition the, adjust the head shape, head position, reposition the mask, and S stands for suction, O stands for opening the airway, P stands for increasing the pressure, and A stands for alternative airway, which is inserting a laryngeal mask or into endotracheal tube. So you have chest compressions which will follow. If the heart rate is below 60, then you have, after the chest compression and IPPV, still no response, you have to give medication which is adrenaline. And adrenaline can be given as an emergency through the endotracheal tube, but usually we prefer to put in the umbilical venous catheter. So all this comes into the sequence. So either the baby is well or not well, and if the baby is not well, you go step by step. So first step is to get the chest rise and the oxygen going. If it's not alone enough, you go to the next step. We have to adjust the oxygen that we deliver according to the saturation targets. We have a chart which gives us the age of the baby, because when the baby is in the tummy, the oxygen is very low. And after birth, it gradually increases. So it takes 5 minutes or so to reach even 85% oxygen. So you have to titrate. We don't want to give too much oxygen because oxygen can be toxic. So we adjust the level of oxygen we give to the saturation target for that age of the baby.
Great. So, Dr. Sridhar, how do you decide when to escalate interventions and utilize advanced life support measures in units?
So one of the key points here is escalation should be early. So you don't want to wait till escalation can be calling for help or calling your code. All the hospitals have a system called code blue or code pink, whatever you may call it. So the code system is a way to quickly get the manpower needed who are expert in the field. So normally it may be a junior doctor attending the delivery, or it may be a midwife or a nurse who is trained in NRP. But if there are risk factors, you call the senior, like a specialist trainee or fellow, and then the consultant themselves may be involved according to the setup you work. If it's a very premature delivery or multiple pregnancies, you already planned the team. So in these cases, it's easier to do all-out resuscitation. But where you don't anticipate, you have to call for help early. And you have to recognize that you are in a situation where you need additional support. And so you bring in the help early. You may need to do advanced resuscitation, which entails, we discussed the algorithm for the normal resuscitation. Even for this, it's better to have two people if you're going down the sequence. at least 2 people, because someone has to manage the airway, someone has to do chest compression, and by that time, when it comes to the advanced, you insert the umbilical venous catheter, you're getting the chest leads, you may have rhythm disturbances which you monitor. And if a baby doesn't respond to these measures, you have to think of complications like a pneumothorax. So you need to get an urgent X-ray, you need to put in a chest drain and things like that. So in a premature baby, you may need to give a medicine called surfactant to help the lungs open up. So it's not just the resuscitation, it's the next steps which becomes advanced, where the baby's response or not responding is linked to certain complications. And a good unit is always geared up to face these.
Great. So, Dr. Sridhar, can you discuss the potential long-term health consequence for neonates who require resuscitation and the importance for follow-up care?
So, I mean, many of the parents are aware of need for resuscitation, ABGAR score and everything. So one thing that we as a medical fraternity should tell the parents is the situation-dependent risk to the baby. So majority of the babies who need resuscitation are just a little bit stunned due to the labor process, because during the labor the uterus is contracting, there is less blood flow to the baby, there may be a slight reduction in oxygen, and if you look at the sequence of events that happens when the fetus is deprived of oxygen and blood flow, the baby first stops breathing briefly, that's called primary apnea, and then as a reflex response the brain starts gasping response, so the baby has a period of fast breathing, gasping starts, and then the secondary apnea, which is a more prolonged, more difficult stage, happens. So if the baby goes into secondary apnea, you have a pale baby who is very floppy because the blood flow to the brain is reduced. So this is a more serious situation. Suppose the baby comes blue, but on rubbing the baby or starting deep breaths, the baby starts crying. That's a good sign. The baby is not insignificant asphyxial injury and is responding quickly. But a baby who is pale, who is floppy, who needs significant prolonged resuscitation. So we have some tools to measure the response. The ABGAR score, for example, we have the COT gases. Remember that these are only markers. These are not absolute. We also look at the progression during the labor, the fetal distress parameters, how long the baby had a low heart rate in the delivery area, whether the COT gas was significantly acidotic, which indicates that the baby had reduced oxygen and blood flow. So all these affect the impact. If it's a premature baby who needs resuscitation, but the baby has come out in a good condition, there is no immediate risk to the brain, apart from what is the risk from being born premature. But in a baby who is born through fetal distress, where you have acidosis, this is called birth asphyxia, and this leads to a risk of what we call hypoxic ischemic encephalopathy, or HIE. HIE is nothing but reduced flow to the brain, the hypotension, the low oxygen, which causes ischemic injury to certain portions of the brain. How far the brain is affected, which areas are affected, depends on how severe the problem is. And obviously, the prognosis can be affected by this. So the baby's future outcome can be affected. If the baby has significant neurologic manifestations like seizure or coma, we do have options now to do therapeutic hypothermia in a neurologically abnormal baby coming through the setting to reduce the risk to the brain. But obviously, there is a risk to the brain despite all this. The proper resuscitation, good care of the baby, therapeutic hypothermia where it is indicated, maintaining the blood sugar, maintaining the temperature of the baby, everything is important after the delivery. Prompt resuscitation is key as well, but how the baby responds after birth, whether the baby has seizures, whether the baby has floppiness, whether the baby tolerates the suck feeds, all this will guide us. The baby who has symptoms of neurologic problems, we do the MRI scan of the brain, which can give us a guide as well. So these are things which can help you to prognosticate. If the baby had seizures, if the baby is neurologically abnormal, definitely the risk is higher. And any baby where we categorize as a high risk, we start early intervention treatment, where there is physiotherapy, occupational therapy, neurodevelopmental pediatrician, or a neurologist monitoring the baby. So these will help us to support the baby's development, because the brain can develop outside the womb in a normal way if we stimulate. So even a baby who has a brain injury doesn't necessarily mean the baby will be handicapped for life. There are things which we can do to improve the outcome and reduce the sequel. So that's why early intervention, being in a setup where you can stimulate the baby in an appropriate way, may reduce the impact. But despite all this, there are babies who get problems like cerebral palsy, hearing loss, vision loss, mental retardation or learning difficulty as we call it. So all these might happen. That's a small number of babies. Suppose we have severe hypoxic ischemic encephalopathy, which is grade 2 to 3. In grade 2, about 40% of the babies will have sequelae, while in the grade 3, which is comatose babies, were very severe. Quite a high number, 70% or so may have brain damage or even more. There's a high risk of losing these babies as well. So to put it in short, obviously, most of the babies who need resuscitation develop normally. So they may have very mild HAE, which is stage 1, or they may not have any HAE. And in a premature baby who needs resuscitation, it's not going to impact the development directly. But prematurity itself has impacts on the brain, which we'll discuss later as well. So in this case, I mean, if the baby had birth asphyxia, had significant HAE, then the risk is more. And in these babies, you need to channel your efforts to optimize the brain development.
Great. So, Dr. Sridhar, from Preventive Care Scope, how can we optimize delivery room practices and identify high-risk pregnancies so potentially prevent the need for resuscitation altogether?
It's not possible to prevent the need for resuscitation in all the cases. Obviously, the obstetric care has to be optimized. Booking of pregnancy and following up with the doctor, so they are aware of what problems to anticipate. So you can anticipate problems and appropriate obstetric decision making. The team works together. There is labor monitoring with the CTG, for example, and then they make the decision to do a cesarean section in a timely fashion. This can reduce the risk to the baby, but there are always cases where you cannot anticipate, and a mother, even in a booked pregnancy, they may come suddenly with bleeding, or I said about cord prolapse and sentinel event. So you cannot always prevent need for resuscitation. That's why every hospital who delivers mothers should have a resuscitation team within the hospital. It's not enough to have them on call, and the expert should be able to intervene immediately. As for the outcome optimizing, it's similar to what we discussed in the very beginning. The team has to be aware of their situation. They need to be prepared to work together as a team. And one of the important things that NRP recommends, as well as the units, especially those who don't face resuscitation scenarios in a detailed way frequently, should do something called skill drills or scenario-based teaching. So skill drill is where you have a mock code. You just call the code as a drill, and you have the same equipment that's used, the same team who manages the baby, and there is someone who leads it, who gives a scenario. For example, you may give a baby who is born through meconium stained liquor, who is not breathing, and then step by step, when the resuscitator does the steps, the one who is running it will tell them that the baby is responding. So during the NRP itself, we have similar scenarios, and the same can be applied. This helps the team to follow the sequence. This helps you to act systematically. It helps you to identify gaps. Suppose you have to put umbilical venous catheter and you realize that your trolley isn't organized to do it in a quick way, because in the real resuscitation, time is of essence. Or you may be finding it difficult to get the X-ray to come quickly to do. If the baby is not responding, you need to rule out a pneumothorax or something. Then you need to look at those aspects, how you can improve. For example, we can put the UVC kit in a small packet and keep it in the kit so it's ready to take, and you're not searching around in a box to take the things out. So being organized and regular training in a country like UAE, obviously the regulator like the DOH always checks if the doctors and nurses have completed the NRP on a 2-year schedule. But if you are working in a developing country, the hospital itself may not take the onus, and the hospital management, the head of the department, they have the responsibility to make sure the team is adequately trained, and they need to motivate the team to run these skill drills, because it can be considered boring by some people because they know the theory, but it's about the practical application of it, how they work together as a team, and if your thinking is stimulated in the right way to act at the right time. So it's key to know that your team works together, especially where you don't do it frequently in a small unit. It's very important to do it well.
Great. Respect to its life-saving process, Dr. Sridhar, how can neonatologists and the pediatrician and the nurseries and other healthcare professionals collaborate for optimal outcome?
Yes, I mean, obviously, participating in research is important in this field. If you are in a big university hospital, you may play a role in guiding. There are many studies which are coming out on delayed cord clamping, for example, and now even in babies who need resuscitation, you can start the resuscitation by the mother's side. There are trolleys called Sure Start, and you can make a system where you start giving breaths to the baby before you clamp the cord, because the lung needs to open. the blood needs to enter the lungs so you don't deprive. Collaboration in these skill drills together. So the pediatricians, neonatologists, the midwives, everyone comes together. You have perinatal meetings, the morbidity meetings, which you can run in your hospital, or if it's a small hospital, you can combine with other units nearby you. Here you discuss issues which affect, for example, the cesarean rate. You may discuss the delivery of babies before a certain stage. So, I mean, if we deliver before 39 weeks, it's not good for the baby. So, if you do a cesarean delivery at 37 weeks, for example, the baby may have a higher chance of needing resuscitation or admission to the NICU. So, collaboration within the team to communicate with issues which can lead to resuscitation or which can improve the outcome of the baby, breastfeeding rates, for example, delayed cord clamping rates. So the pediatrician, neonatologist, obstetrician, midwife, everyone works together, they collaborate. If you come across any new research which will affect your approach, you communicate it to the team. So for example, we have a WhatsApp group within our obstetric and pediatric teams together. And if it's something related to nursing, we share it with the nursing heads who will share it with their team as well. And we have to teach as we go on. So teaching and learning should stimulate the whole team as well. And feedback. I mean, if there is an incident, looking at the root cause analysis of why the incident happened. Any resuscitation scenario is considered an incident and you debrief at the end of it. And the team should learn how to debrief in a way that they don't hurt the sentiments of the team involved. They are positive at the same time. They don't miss out any points that need improvement. So you can do audits on this. You can have quality improvement projects on this. So all this will help you change the outcome as well.
Great. So, Dr. Sridhar, which is very critical to be updated for all healthcare professionals. So, how can physicians stay updated on the latest advancement in neonatal resuscitation techniques and best practice?
So, obviously, we discussed that when we said that every 2 years you need to do the NRP. So, whenever there is an NRP update, you get an email from the Heart Association or from your management. And then when you do the retraining, you may do it with the new NRP. So every 4 years or so you get a revision of it, and every 2 years you get an update. So the update itself changes. Like last year we had an update which told about cord milking, which can be done about 28 weeks in the premature baby. So changes like that, the oxygen saturation target, the approach to meconium aspiration babies, even the initial sequence in the algorithm. So warm, dry, stimulate, position, suction, and these sequence of events were rearranged to make it more practical. So every few years there are changes like this, and the people who attend the course, when they come for the skill drill, they will update the team, and that's incorporated automatically. So you don't need to wait for you're doing the new NRP skill, but you keep looking at the journals, you look at the communication, and you disseminate within your team when there is a change. So usually the American Heart Association sends out the updates a year or so in advance, and then the new edition starts coming into application the next year. So for example, we get the information in December and then it starts getting applied in June or so. So you have a few months ahead before it becomes mandatory to apply it, but during the initial phase itself, you teach your team and disseminate the information. This is the main way, and of course you have to read other things like articles related to oxygen, cord clamping, brain outcome. So this will improve your communication, especially if you are a neonatologist and a team leader. Your role expands more, so you have a futuristic vision of what's happening when you lead the resuscitation. It's sometimes difficult to stop the resuscitation. The baby isn't responding, but when you know the outcome is poor, it impacts on the family in the long term, you have to take that call. So you have to know the full picture and the future impact as well when you make decisions like that. And the medico-legal part. So most important to stress that NRP deals with life-saving skills and documentation, careful documentation without incriminating anyone in the team. For example, you shouldn't criticize obstetric management. The obstetric management is up to the obstetrician to explain in detail. You may feel that it could be done differently, that can be discussed at the debriefing, but your aim is not to criticize them in your documentation. You may not know the full picture. You don't really know why they acted in such a way. So there are forums for it, the administration team. So if you think something could be done differently, you feedback to them, but your documentation should be clear about your focus on how the baby is responding, what you did. And remember that even minor things like pulse oximeter readings when you're doing chest compression are not the exact correct resuscitation. So you don't document it if the heart rate is coming 40 on that. you go by what you listen to the chest and document it. So the team should be clear about how to approach documentation, communication with the family, make sure that they are involved in it and they are supported through it. It's a very difficult process, and debrief the team, debrief the family, explain everything to them in a compassionate way. All these terminologies come in: empathy, communication, documentation. Remember the medico-legal risk always. When you document anything, don't take anything loose. It has to be taken seriously.
Great. Finally, at the end of our episode, I need to thank you so much, Dr. Sridhar, for your valuable insights and sharing your medical knowledge with us on MedSynapse platform. Thank you so much for having you today.
Thank you. And I would like to add that, I'm sharing the link to the NRP, the full video I made on NRP 8th edition. And please go through that. And also there are many videos for physicians and parents on my YouTube channel. So you can go through that as well. So I request the audience to make use of it. It's quite easy to find it on YouTube, but from the link she shares, you can reach the channel. Thank you.
Of course, it will be valuable resource for all physicians. Thank you so much, Dr. Sridhar.